Anaphylaxis is a severe life-threatening reaction which can occur at any point in any individual. To spot anaphylaxis, we use the A, B, C, D, E approach. Patients who suffer from anaphylaxis will present with a variety of symptoms. Each time their symptoms can vary, and each time their symptoms can differ and become more severe. The slide illustrates some of the symptoms that might be present in anaphylaxis. Our concern is if there is significant airway problems, breathing problems, or circulation. From a differential diagnosis point of view, in anaphylaxis, generally you're tachycardic, flushed, you will probably have a rash, but the anaphylaxis patient does not improve spontaneously. If somebody faints, they tend to be bradycardic, pale, won't have a rash, but they do improve spontaneously. The rash in anaphylaxis is very common. 80% of all cases in anaphylaxis develop a rash. Once you've made the decision that it is anaphylaxis, you need to follow the Resuscitation Council anaphylaxis protocol, which is available on the extranet. It's also available via the iResus app. The key element here is what is your plan in the way in which you're going to treat them. Firstly, if you know the allergen, remove it. You then need to get help. If you work in the community, dial 999. If you work at Conquest or Eastbourne DGH, you need to dial 2222 and ask for a cardiac arrest team, even though the patient hasn't had a cardiac arrest yet. Follow the Resus Council protocol until help comes and/or the patient improves. The key element in treating anaphylaxis is to give adrenaline. Adrenaline comes in a variety of solutions and doses. The solution for anaphylaxis is 1 in 1,000. The dose for an adult patient is 0.5 milligrams. In terms of volume, that is 0.5 of a ml. If the patient is 6 to 12 years, we give 0.3 milligrams, which is 0.3 ml. If they're 0 to 6 years, we give 0.15 milligrams, which is 0.15 of a ml. Adrenaline in anaphylaxis is routinely given via the IM route. Certain clinicians may prefer to give IV adrenaline, but it must be stressed that this is potentially life-threatening, so should only be used with extreme caution. The onset of action of adrenaline in anaphylaxis is approximately 1 to 2 minutes, but the half-life is only 5 minutes. Therefore, if your patient has not improved or is clinically deteriorating at 5 minutes, repeat the dose. You can give adrenaline until the patient improves or suffers a cardiac arrest. There is no maximum dose of IM adrenaline. Currently in the United Kingdom, there are 3 different types of adrenaline auto-injectors. Emerade comes in a white container. Emerade has 3 doses, 0.15, 0.3 and 0.5 milligrams. To use Emerade, you remove the white cap. Emerade is different to the other 2 auto-injectors. The cap end is the same end as the needle end. So you remove the cap, hold it however you wish, left hand or right hand, rest the device on the leg, push and hold in place for 5 seconds. Once you've done so, remove the device and a needle guard will come down. The next auto-injector is EpiPen. EpiPen only comes in 2 doses, 0.15 milligrams and 0.3 milligrams. To use EpiPen, once you've taken it out of its box and plastic container, remove the blue cap. The needle end is the opposite end of the cap end. So the needle end with EpiPen is the orange end. Rest the device on the leg, push and hold in situ for 3 seconds, after which remove the device and again a needle guard will come down. And finally, the third auto-injector is Jext. Jext comes in 0.3mg and 0.15mg. When you've taken it out of the box and plastic container, remove the yellow cap. The needle end is the black end, so it's the opposite end of the cap end. Rest it on the thigh, push and hold in situ for 10 seconds. Our teaching within ESHT is whatever auto-injector you use, to keep it in situ for 10 seconds, and then that way you can't go too far wrong. Having injected adrenaline, hopefully your patient will improve. If they don't, you can consider other drugs. If the patient is profoundly hypotensive, so the blood pressure is less than 90 systolic, you could consider a fluid challenge of either normal saline, Hartmann's or Plasmolite. If they still have refractory bronchospasm despite the adrenaline, you could consider giving salbutamol or ipratropium. The question is often asked about Piriton and steroids. Antihistamines and steroids are acceptable, but they are secondary, not primary management. So if the patient is hemodynamically stable, you can consider them, but only when your patient is hemodynamically stable. Biphasic reactions are fairly common in anaphylaxis, and therefore we do need to be mindful of not discharging patients without appropriate care and treatment. So how quickly will your patient suffer a cardiac arrest from anaphylaxis is partly cardiac arrest in anaphylaxis is partly depends on what you get exposed to and how you get exposed to the allergen. The study from Pumphrey in 2000, Pumphrey illustrated this by studying 164 cases of fatal anaphylaxis within the UK. And as you can see, that drugs that are injected, the average time to cardiac arrest is approximately 20 minutes. So from a training point of view and from a prescription perspective, the resus department will provide training for schools, colleges and patients that have an auto-injector. Please refer them to the resus department via the referral form which is on the extranet. If you are a prescriber, please follow the MHRA guidance of May 2014 that states that all patients should be prescribed 2 adrenaline auto-injectors. If you have any questions, please contact the numbers on the screen.